So we'll give everybody just a couple more seconds to get logged in. So once again, my name is Dr. Amber Adams. I'm a nurse educator here at bootcamp.com. I've personally been a nurse for about 14 years, and most of my experience was in emergency nursing. So I did a lot of prioritization in the ER, which you of course do in any area of nursing. And I also have a wonderful nurse educator joining me in the chat. She's going to be our moderator today, Miss Miriam. She'll be answering any questions y'all have, as well as sharing some information throughout the webinar. So while we're waiting for everyone to get here, I just want to remind you all that if you have any friends that are studying for NCLEX or just want more study resources, please make sure to invite them to the study group so they can get access to all kinds of study resources to make sure that you feel well prepared for NCLEX, and also so they can join in on these webinars going forward, because we do many different topics. All of them will help you be successful on NCLEX. Okay. So we'll go ahead and get started with our presentation to get everybody feeling comfortable with prioritization. Okay, so today we are going to talk about why prioritization is important. We're going to walk through how to approach the whole process of prioritization, both as it pertains to questions, but also, once again, when you're in the clinical setting taking care of your patients, because that's when it's, of course, most important. And then we are going to walk through a couple of different styles of prioritization questions. So the reason we chose this topic is because, one, it is one of the most important skills as a nurse to be able to successfully prioritize. But also, it is a guarantee that you will see prioritization questions on NCLEX. So we all know the whole purpose of NCLEX is to be able to measure your critical thinking, your clinical reasoning, and your clinical judgment. And these questions are one of the best ways to do it. So just to give you a little bit of perspective, when you go to take NCLEX, management of care questions or management topics account for about 15 to 21% of the items you'll see on the exam. And a lot of these questions are prioritization. And then, as I said earlier, it is so important to be able to successfully prioritize when we are actually at the bedside looking at a patient and trying to figure out, what do I need to do first? So with my experience as a nurse faculty member, I have worked both in the clinical setting and the classroom setting. And it is not uncommon that I have students say to me, which patient do I see first? Which task do I perform first? Which order do I do first? And so that's what today is going to be all about. So overall, the best thing we can do when we are approaching prioritization is to start by just looking at the overall client picture. We should look at that patient and try to figure out, what is the progression for them? What is the disease process progression? What is going to be the outcome of any task we perform or anything we're doing with our patient? And look at what that is going to do for that patient overall, and really look at it once again with that overall picture in mind. Now, this can be kind of difficult as a nursing student and even as a new graduate nurse, because you typically don't have a great deal of experience with that typical client progression and how it looks, as well as how complications will present. So before we move on to practice questions, I do want to let y'all know that prioritization questions can be formatted many different ways. We may be asked to choose among 4 clients, or we may be asked to choose among 4 tasks or 4 different things we need to do. And then sometimes we may be even asked to work backwards, where we're having to choose what is the least urgent or the lowest priority patient or task. So we're going to look at different examples today, different formatting, so you feel comfortable with all these different styles. The last thing I want to mention about priority questions before we move into practicing is that there's many different words you may see in that question stem. Most important, priority finding, priority client, most urgent, least urgent, but all of these are just examples of priority questions. So before we jump into the questions, I want to show y'all a really cool resource that we've put together here at bootcamp.com. All of our nurses have many years of experience in many different specialties, and we all work together to try to figure out what is a way we can consolidate or combine all the knowledge that we have gained on prioritization to make an easy tool for students and nurses to use when they're approaching prioritization? And we were able to develop this prioritization pyramid to help you navigate and strategically approach prioritization. And we're going to use this and apply it in all our practice questions today. So it starts with step 1, which is just eliminating stable and chronic issues. So anytime we have a client that is very stable or is experiencing a chronic ongoing issue, they are typically not going to be our highest priority patient. So let's give a brief example of those. A stable client might be a patient with, just a bruise and no other symptoms, or maybe a minor fracture, a small fracture with mild pain at the site and no other symptoms, no signs of complications. They are very stable. They're not typically going to be our highest priority client. A chronic issue might be a client with advanced COPD with a pulse oximetry reading of 92% or 93%. We would expect this in a client with advanced COPD. However, if our client with a mild fracture had a decreased pulse oximetry reading, that would be a little more concerning. But for a client with advanced COPD, we anticipate a low oxygen saturation. So both of these examples are going to be patients that are typically not going to be our highest priority once again. And then after step 1, once we've eliminated these stable and chronic issues, we're going to move on to that pyramid. And this is going to help us be able to choose when we're looking at 4 different patients or 4 different tasks. It's going to help us figure out what is really our highest priority. So our highest priority in red is usually going to be acute airway issues and immediate safety issues. And when I say immediate safety issues, I'm referring to tasks and situations where if we delay anything, there's going to be a poor outcome for our patient or immediate threat to our patient. And then we move on to breathing, circulation, and disability. And disability is referring to neurological issues. But just to make it easy, A, B, C, D is typically how we're prioritizing. And then our lowest priority tasks are going to be here at the top of the pyramid in green. That's going to be routine tasks, expected findings, and psychosocial needs. Now, of course, we want to make sure our patient's psychosocial needs are met, but typically a patient being frustrated with you is not going to kill them. And that is really what prioritization is all about. We need to be asking ourselves, what is going to kill our patient fastest? And that's going to help us determine who we need to see first and what we need to do first. So I know that was a lot of information, but we're going to use that in the next couple of questions so it'll make a little more sense. Okay, so let's start with our first prioritization practice question. And once again, we have to start by just looking at our header and stem and figuring out what exactly is this question even asking us, because they once again can be formatted in many different ways. So in this question, we are asked, the nurse should first assess the client who. So first assess. So we are looking for the patient that is the highest priority. Now, I wanted to start with this while everybody's all the way awake and just joining. This type of formatting is very common. This is probably the most common style of prioritization question you're going to see, where you have 4 different clients and you're having to look at each picture, each overall client picture, and determine which client is sickest or which is the highest priority. So let's look at our options. We first have a patient that is obtunded or has decreased mental status, is on hospice care, and is becoming restless. Option 2, a client that just had a cholecystectomy or a gallbladder removal 2 hours ago and is reporting nausea. Option 3 has a peptic ulcer with a rigid abdomen and is reporting sharp abdominal pain. And 4, a client who had abdominal surgery 2 days prior and is reporting left lower extremity pain and swelling. So let's look at these options a little bit closer. So option 1, they're obtunded and becoming restless. So I want to take this moment to remind everyone it is never a good idea on any question, but especially prioritization questions, to not latch on to one word. Don't look for keywords that can get you in trouble with this style of question. Because, for example, if we saw a patient and they were becoming restless and there was a change in their mental status, we would automatically probably be pretty concerned. But the key word in this option is they are on hospice care. So for this client, they have a terminal illness, and we can anticipate if a patient is actively dying that they're going to have a change in mental status, they're going to become obtunded, and potentially become restless or anxious. So let's bring it over to our pyramid here and figure out where it goes. So this isn't really a stable or a chronic issue because they are becoming restless or they're actively experiencing a change in their mental status. But if we look over on our pyramid, this is really an expected finding. We expect a client that is on hospice care to have a change in mental status. So I would say we'll put it right here at the top of our pyramid, option 1. But let's look at our other options. So option 2, our patient had a cholecystectomy or gallbladder removal 2 hours ago, and now they are nauseated. So this is an acute issue, so we'll go ahead and go to our pyramid, and let's try to figure out, is this an expected finding? So do you think a patient that just had a gallbladder removal 2 hours ago, is it expected for them to have some nausea? I think so. I mean, we just had a client that had anesthesia, which we know can make a patient nauseated. They also just had an abdominal surgery, and then gallbladder issues alone can cause nausea. So this is an expected finding for this client. So we'll go ahead and put them also at the top of our pyramid for expected findings. So let's move on to option 3. We have a client with a peptic ulcer with a rigid abdomen reporting sharp abdominal pain. So what do we think is going on with this patient? If they have a peptic ulcer and they have abdominal rigidity or abdominal firmness, and now they're experiencing a lot of pain, what is our concern? Yeah, we should be worried about perforation. So anytime we have abdominal rigidity, that is a very concerning finding. A lot of times that can be found with peritonitis or inflammation of that peritoneal sac. And if left untreated, what can happen with this patient? Anytime you have peritonitis and it's left untreated, we're at risk for systemic infection, for sepsis, and this can get very dangerous very fast. So if we bring it over to our pyramid, I would say that falls as probably kind of a circulation issue. So then let's look at option 4. We have a patient who had abdominal surgery 2 days prior that now has left lower extremity pain and swelling. So anytime we have a patient that had surgery a couple days ago and now they're having unilateral extremity pain and swelling, what are we worried about? We should be worried about a blood clot, a DVT. So this patient is having, once again, left lower extremity pain and swelling, so there's a good chance they might have developed a DVT. So we once again bring it to our pyramid, and that's also a circulation issue. So then that's where it gets a little tricky. We have 2 clients that both are having circulation issues. So we have to figure out basically which one is more life-threatening. So in this case, we have the client with a peptic ulcer with abdominal rigidity. So peritonitis is kind of a systemic issue, and it can progress very rapidly. Whereas our client with the DVT, of course it's still concerning, but right now it's localized to that one extremity. So option 3 is going to probably be our higher priority client. But let's talk about when option 4 could potentially have been a higher priority. What if the option said instead, we have a patient that has left lower extremity pain and swelling, and now they're experiencing anxiety. They're having shortness of breath. They're tachycardic. What are we most concerned about now? It's going to be a pulmonary embolism. Maybe that clot broke off and they're having symptoms of a pulmonary embolism. And if we look at our pyramid, then that becomes a breathing issue. And if that was the case, option 4 would be the higher priority. But that is why we should not add information to the options. I know that that is easy to do. It's a common issue students face, but remember, don't add information to these styles of questions. Don't overthink them. Just simply look at the information that you have in front of you. So once again, option 3 is going to be our highest priority client we need to see first because it poses the highest life-threatening risk to our patient. So hopefully that helped you a little bit navigate that style of choosing amongst 4 clients, because once again, that is the most common style of prioritization question you will see. But let's look at some other styles that you may experience. So the nurse has been made aware of the following client situations. Which of the following client needs should receive the highest priority? So this question is saying client needs or tasks. So we are now having to switch gears just a little bit and figure out which task should we perform first. So let's look at our options. Option 1, administer an antibiotic to a client with cellulitis that was due 1 hour ago. 2, assess the client who reports redness and pain at the appendectomy incision site. 3, assign assistive personnel to stay with the client who is reporting suicidal ideations with a plan. And option 4, provide discharge education to a frustrated client who has been requesting discharge paperwork for 2 hours. So let's look at these a little bit closer and see if we can figure this out. So option 1, we're administering an antibiotic to a client with cellulitis that was due 1 hour ago. So we know medication administration is a time-sensitive task, and we do want to complete it as quick as possible. But if we delay that antibiotic briefly or temporarily, will it most likely lead to a life-threatening complication, or is there a life-threatening immediate risk to that patient? Typically not, but let's look at our other options and see if any of them are lower priority. So option 2, we have a client with redness and pain at their surgical site. So redness and pain. Anytime I have a client with redness and pain at a surgical site, what should I be most concerned with or about? It's going to be an infection. So we certainly want to intervene. We want to assess this patient, notify the provider. But is there an immediate risk or a life-threatening issue if I delay assessing this client for a little while? Once again, probably not. Let's look at the rest. So option 3, assign assistive personnel to stay with a client who is reporting suicidal ideations with a plan. So we know suicidal ideations are already concerning. But whenever they have a plan, they've had time to think this through, and they're usually pretty serious about this idea. So that makes it even a higher priority. So suicidal ideations with a plan, if I do not intervene, if I do not find somebody to sit with this client, is there a life-threatening risk to this client? Yeah, so far they're a pretty high priority, but let's also look at option 4, of course. So provide discharge education to a frustrated client who has been requesting discharge paperwork for 2 hours. So for this client, they're frustrated, they've been waiting 2 hours, and I sympathize with them. I'd be frustrated too. But a patient being frustrated, if we don't immediately bring them their papers, is there going to be any type of risk, life-threatening risk to them? No. There's not going to be any type of physiological risk with them just being frustrated. Because once again, if we look at our little pyramid, that psychosocial need at the top, so it is a very low priority client. Whereas option 3, suicidal ideation with a plan, is going to be down here in red. That's a huge safety issue. So what do we think is the first thing we need to do out of these 4 tasks? If you said option 3, you got it correct, because it is the only task that poses an immediate threat to the client. And if we delay it, it could result in life-threatening complications for this client. So let's do one more practice question, and this time we're going to work a little backwards. In this one, we are going to choose the lowest priority client. So the nurse is caring for admitted clients who were involved in a mass casualty incident. The nurse must discharge a client to make a bed available for other injured clients. It would be most appropriate for the nurse to recommend discharging which client. So once again, we hopefully are only discharging low priority clients, not high priority clients. So it's asking us to once again work a little backwards. So let's look at our option. Option 1, a contusion to the chest wall with a heart rate of 110. Option 2, soot around the nose and mouth and a respiratory rate of 30. Option 3, a headache and bruising behind the ear following a head injury. And option 4, superficial non-bleeding abrasions to the face and upper extremities. So let's look at these a little closer. So a contusion to the chest wall and a heart rate of 110. So is a heart rate of 110 normal? No, it's a little bit fast. Our patient's tachycardic. And then they have a bruise to their chest. So as a nurse, if we have a patient that had a trauma to their chest or bruising to the chest, and now they have tachycardia, is there any specific disease process or condition I should be concerned about? Anything come to mind? Me personally, I'm going to worry about cardiac tamponade or fluid buildup in that pericardial sac around the heart. And when that happens, that heart can't pump efficiently because there's fluid compressing it. So can this be life-threatening? Yeah. And let's look at our pyramid. Where would this fall? A contusion to the chest with a heart rate of 110 is going to be a circulation issue here. So it's a pretty high priority. Let's look at the rest though. So option 2, soot around the nose and mouth and a respiratory rate of 30. So once again, is that respiratory rate normal? No, that client's a little bit tachypnic, and then they have soot around their nose and mouth, or ash. So even if we weren't looking at that respiratory rate, if we just found out that we had a client that has soot around their nose and mouth, is there any condition that automatically comes to mind that I should worry about? An inhalation injury. Anytime there's soot or ash around the mouth or nose, we need to be concerned about an inhalation injury. And of course, inhalation injuries, depending on the severity, can become airway or breathing issues. So either way, it's a very high priority client. So both with options 1 and 2, would y'all feel comfortable discharging them home? I hope not. I would not. So let's look at our other options. Option 3, a headache and bruising behind the ear following a head injury. So what would be your concern? These are certainly not normal findings. Anytime a client comes in after a head injury, if they have bruising behind the ear and a headache, is there any conditions we need to be concerned about? Well, anytime I see bruising behind the ear, I'm going to be concerned about a basilar skull fracture, but they also could have intracranial bleeding. So with all these types of conditions, are we probably safe to discharge them? No. And if we put it over here in our pyramid, we could put it under neurological for disability. If it was a intracranial bleeding, it could be a circulation issue. But once again, the point is these are all pretty high priority clients that I would not feel comfortable discharging home. So let's look at our last option. We have a client with superficial non-bleeding abrasions to the face and upper extremities. So for this client, are they stable? I'd say so. We might want to do some wound care to prevent infection, but for the most part, when we compare them to all these other options, they kind of fall even outside of our pyramid, right here with stable issues. So we can go ahead and hopefully figure out that amongst the 4, option 4 is going to be the only patient that is safe to discharge home. So option 4. And once again, because that client has no immediate risk to their health, any major life-threatening issues. So hopefully those questions gave you a little bit better idea of prioritization questions and gave you a more well-rounded approach to the different styles of questions you may see. So once again, although prioritization questions can be intimidating, They are much more manageable if we take our time to really pay attention to what that header and that stem are asking us and really looking at each option, not looking for keywords, not just automatically trying to find an airway or a breathing issue, but really figuring out what is the overall picture with our client and using the prioritization principles that we've discussed today to best discern or figure out what is really my highest priority, which client has the most risk, life-threatening risk. And once again, we can do this by just ruling out any stable or chronic issues and then utilizing our pyramid to figure out what is really the highest versus lowest priority. So I want you all, once again, please to invite your friends to join us in the study group so they can feel well prepared for NCLEX as well, and they can join us for any webinars going forward. So is there any questions y'all have about the items that we addressed today, or any questions you have overall about prioritization? Of course. I was very excited when I was asked to talk about prioritization because once again, I know that this is a very intimidating skill as a new nurse and for nursing students. Suppose nothing comes to mind when you read an option. Well, really not quite sure how to answer that question, but certainly I would just ask myself, is there any patient that I'm looking at or any task where if I don't address it, it's going to become a safety issue for my patient or an immediate life-threatening risk? Because typically if you look a little closer, there is. Just look very closely at the keywords. Yes, this is going to be recorded so you can watch it again. Oh, good luck on your exam tomorrow. That is very exciting. I know you'll do well. Okay, well, I guess we'll go ahead and we're going to end this webinar for now, but once again, we have weekly NCLEX webinars. We hope to join you in the future. I hope this information was helpful to you all, and I want to thank you all so much again for participating today, and I hope you all have a wonderful rest of your day.